Okay, so welcome to everyone who's logged into this webinar. So this is the Stone Research Foundation 2025 update. And let me give you a little bit of color about who we are for those of you who don't know, and just a little focus on what we're drilling down on in the research side of our life here at the Stone Research Foundation in San Francisco. So first of all, the what we're about is how do we keep you playing forever? And you're going to hear this over and over again. And our research is on how to accelerate healing, how to treat, prevent, and cure arthritis. That's the mission. So let me explain a little bit. Many of you know me as an orthopedic surgeon, and you know I'm passionate about not just taking great care of each and every one of you, but trying to figure out how do I do each procedure, how do I deliver each non-surgical intervention a little bit better every single time that we do it. And fundamentally, I don't believe that a doctor should do something to or put something in a patient that they either don't know the outcome or aren't trying to figure out the outcomes. And so I'm very fortunate to have the clinic here in San Francisco, but also to have a world-class team in the Stone Research Foundation entering almost every patient into an outcome study, and at the same time driving forward basic science research to see if we can make every one of these techniques better and better and better. So we're going to take some time in this webinar to just drill down on a few of the areas that we're focused on that we think it's most important for you to know about, and share our passion for caring for you and helping you play forever with you and with others around the world. Next slide. And so our vision is, can we accelerate healing? And can we treat, prevent, and cure arthritis? So when I say accelerate healing, if I ask someone a year later after their knee surgery, what was the worst thing about it? They rarely tell me it was the pain. They almost always say it was the muscle atrophy that they had to overcome. Or they'd say, well, why did it take me a year to get back from my Achilles injury or my ACL injury or my rotator cuff injury? Can't we accelerate this? We're living in what I call the anabolic era of orthopedics, where we don't just fix something, we add growth factors and cells and other things to see if we can speed up the way the body lays down new collagen and heals the tissues. And I believe that many of the injuries that we've spent a year recovering from, we could really have accelerated that healing, get the tissues to heal earlier, stronger, better, and have you return to sport, as we like to say, fitter, faster, and stronger than you've been in years. So we're going to talk to you about how we're doing that, how the foundation is focused on the research critical to being sure that any therapies we add to your joint or to your tissues, in fact, are the best ones we possibly could add. And then the treat, prevent, and cure arthritis side of this. So for years, we've been treating and working on preventing arthritis. We just never knew if we could cure it. And one of our wonderful patients many years ago said, listen, if you can regrow cartilage in arthritic knees, if you can replace the meniscus in arthritic knees, you're going to cure arthritis. And you should focus on curing at least that segment of arthritis that people get after they lose their meniscus or damage their articular cartilage. And so we're going to show you the work we're doing on trying to treat, prevent, and cure arthritis. Next. So the impact of all this is clearly, we want you to have a pain-free future. We want you to play sports, live forever, drop dead at age 100, as I like to say, playing the sport you love. As all of you know, there's a huge amount of interest in longevity these days. There's every venture capital group or venture capitalist who comes through as a patient talks to me about how they're funding this, that, or another longevity study. And I look them in the eye and I say, listen, what's the point of living a long time if you can't move? And so a lot of the research we're going to talk to you about is about keeping you moving. And so to do that, we want to advance these regeneration-focused type therapies to keep you going. Next. So, as I mentioned, our goal is to help you live to age 100, playing the sport you love. And if we can do that, we feel like we would have really contributed to your life and the lives of other people around the world. So here's an annual update. Dr. Mani Vessal is the PhD world-class scientist who has been leading our foundation, and he'll introduce the team around the foundation as well. And without him and without the team, we wouldn't get anywhere. And I have to tell you, in my 35, almost 40 years now of working with research teams here at the clinic and in the foundation, this is by far the best team we've ever had. And we're right on the cusp of several really cool things that Mani will go into with you. And by on the cusp, that means that we're just taking it from the lab into animals or people, or we're taking it from animal studies just about to go into people. So we're about to realize a lot of our dreams about, hey, can we accelerate tissue healing? Can we do something that hasn't been done before? And then now can we prove that it works in people? So Dr. Vessal has been running that whole part of our world. He'll go into it for you. And we're very lucky to work with him and the team.
Thank you, Dr. Song. It's a pleasure to see so many faces, some familiar and some that I've had the pleasure to see just in the room as you've been entering. So thank you for taking the time, showing the interest to hear about our research and where we're going with it. First, I'd like to start with our stellar team who has been working diligently, long hours every day to really move along the research pipeline that Dr. Stone and I have developed in the past at least 8 years of my tenure here with the foundation. And moving to the next, I would like to show you a few of faces, some of whom I hope are online with us today, who make this work possible. No one in science can do it on their own. We definitely depend on a strong scientific network of collaborators and partners from various institutions. And here are some of those faces that, again, as I said, help Stone Research Foundation move along and every day make progress in our scientific efforts. So let me talk a little bit about our current research and future pipeline and what we're working on right now. There are 3 parts to our current and future direction of where we are leading to make you feel better, more active, and hopefully pain-free. First is I would like to start with the orthobiologic injections. And this is, of course, there's some pain with injections. So we say non-invasive, but it's not an entirely 100% pain-free. But compared to surgery, it is. I think we all agree on that. And this is to manage your pain for injuries and early stage disease, osteoarthritis. The second part to our research pipeline is what we call ArtCard Plus. And some of you might be familiar and actually are patients of this procedure who have recovered and regained your cartilage to be able to pain-free and to actually move on with your active lives. But we are now working on utilizing regenerative techniques that are available to us to make this even a more successful procedure. And finally, we have the third part of our pipeline. So if you have to undergo the knife, then back up and active and heal faster. And that's the testosterone study that Dr. Stone will do a deep dive on later in the talk. Next. So orthobiologic injections. Let me explain a little bit more about what we mean by that. So here is a study that we planned to perform in full head-to-head of all of the commercially available and used clinically growth factor injections, some with cells, some without cells, that are basically all aimed to reduce your pain and promote cartilage regeneration and preserving your cartilage, and can also be added as an augmentative additive to your surgical procedure for better healing. Going to the next slide, I will show you what I mean by these orthobiologics. So most of you are familiar with PRP, probably, because that is the one that is clinically most prevalent, I would think, not just in orthopedics, but in all the other sort of dermatology and other clinical aspects as well. What we plan to do, direct head-to-head study of synovial fluid-derived mesenchymal stromal cells, which are stem cell, or what I call personally a quasi-stem cell types, that can help recruit your own body's healing factors to the site of injury, reduce inflammation, and also make cartilage. This can be also derived from your own blood in PRP, which, as I said, most of you should be familiar with, and other various aspects and areas of your body, including fat, bone marrow, and the lining of umbilical cord, which gives the Warden's jelly, which is another potent source of these growth factors. Next. This study, we have completed our preliminary in vitro in a dish head-to-head work in Dr. Dan Grandy's lab at Feinstein Institute. He is one of our scientific advisory board members, key collaborator, and a friend. We meet up at different conferences and, of course, discuss science, meet his lab members and his research team. This was an example where we met at one of the orthopedic meetings in Phoenix just a little bit earlier this year. And so we have now finalized our data from this preliminary work where we have done this head-to-head analysis in vitro, and we are now ready to start and commence the large full study that hopefully will be commencing in early 2026. Next. So why are we doing this? I've already said this. The impact for the patients and the impact on the clinical overall benefits for looking at these, all of these various types of growth factors, is to really, the main overarching goal is to reduce pain and inflammation more effectively. Now, we need to establish which one of all of these available growth factors are actually the most potent option, so that we can inform both you, the patient, and the clinicians globally to use that as the best treatment moving forward. And of course, again, at the end, bottom line is to empower your active lifestyles. Next. Okay, so ArtCard Plus is the second in our research pipeline. Now, this is when you need surgery, and what Dr. Stone says, bone to bone or close to, and you need to actually have a new cartilage form. Now, before getting to ArtCard Plus and what we're doing with exciting work that we're actually currently doing on that, I will let Dr. Stone go ahead and describe the procedure and the history of it since it's his invention over 30 years ago. Dr. Stone.
Thanks so much, Mani. So now we're talking about how do you treat isolated injuries to the articular cartilage inside a joint or arthritis. So remember, articular cartilage is the bearing surface of all joints. Crack open the chicken leg, the white shiny surface there, that is articular cartilage. When you get post-traumatic or osteoarthritis, you get a wearing away of that articular cartilage down to the bone, and then it hurts. And so if you have arthritis where there's still some joint space, and that's our key metric, meaning if you're already bone on bone, then we have to go on to a metal type implant. But if you're not bone on bone yet, you have a hole in your bone, as you see in the drawings on this slide, or if you have general thinning of the cartilage down to the bone, but not quite bone on bone, then what we want to do is a biologic joint replacement, meaning rather than put metal and plastic in, we want to regrow that damaged articular cartilage. And so in 1991, just after I had been a fellow with Dick Stedman in Lake Tahoe, I had seen so many of his microfracture patients where the damaged area of bone inside the joint was fractured in order to create a healing response. But some of those patients didn't get success. And it turned out even the ones that did get success, the success only lasted for a short window of time. And so what we said is, listen, is there a way to regrow more potent, more durable, more healthy, more normal articular cartilage? And the way we did this is the following. Our goal was to create a one-step solution for both arthritis and chondral defects. And so next slide. So the way we did this is, first of all, we recognized that small injuries inside someone's joint don't really heal. Bigger injuries where they fracture or they've damaged into the bone marrow healed with a much more robust healing response. So when we would see a skier off the hill, and we were in Lake Tahoe at the time, they'd have a small injury to their cartilage, they'd show up with these cartilage holes in their bone with no healing response. When they fell and crashed from a big downhill injury and they had fractures in the joint and damage to all the tissues, the body created this enormous healing response. And so we said, listen, in these isolated areas of cartilage, or in these dead areas of arthritic joints, what if instead of doing a little microfracture, we did a macrofracture, what we called morselizing the bone, morselizing that area, as you see in the little diagram in the slide. So we'd get down to the marrow cells, which could then pour out of the bone marrow. And back in 1991, I didn't call them stem cells. We now know they're a kind of stem cell, a bone marrow mesenchymal cell. And once those cells would pour up to the surface, if we could provide them with a stimulus to form cartilage and not form bone or scar tissue, then we might be able to regrow cartilage. And what was the stimulus? The stimulus was several things. One, it was whatever the factors are in articular cartilage, that when stem cells see them, they form bone, they form cartilage. And number two, if you add motion to that mixture of articular cartilage and bone, then motion will stimulate the cells to form cartilage, not scar tissue or form bone. And so we created a paste of articular cartilage and bone marrow, formed it into a paste from the patient's own knee. We, as you see in the slide, the image on your right there, where we harvest from the articular cartilage. Go back one slide, please. We harvest from the articular cartilage, and then we take it out of the knee, form it into a paste, and then we pack it back into the defect. And then we put the patient in a CPM, or a motion machine, where they wouldn't walk on it. They'd put their knee in the motion machine for 4 to 6 hours a night. And over the course of 1 month, the new cartilage would form. And we know it would form because in the first 125 of these patients, we went back and did a second look arthroscopy and biopsy. It was part of a IRB approved clinical trial. And we could see the level of development of the articular cartilage. Was it normal cartilage? Was it scar tissue? And about 30% of them developed into perfectly normal cartilage. And the remainder formed in some mixture of fibrocartilage and scar tissue and permitted healing to occur. And so we've been doing that now for 30 years. Let's go to the next slide. And we'll see, this is what a lesion in someone's knee would look like. This was a 17-year-old who had lost a big chunk of cartilage to a disease called osteochondritis dissecans. And we would pack the paste into this hole and then do a second look arthroscopy and see it nicely heal. But only 30% of patients develop normal cartilage. And so the question for the Research Foundation is, listen, how do we make a higher percentage of normal cartilage? How do we get it to heal faster? And how do we get to be able to use it in a much bigger lesion, such as diffuse osteoarthritis? Next slide. So we knew that when we compared paste grafting to all the other cartilage repair procedures that are on the market, paste grafting had the longest number of years of benefit. It was a one-step procedure. It was low cost, minimally invasive. I used it in the ankle and the knee, and it was safe in patients, even patients over 50 years of age. Next. So these good results, in fact, some of them great results, but the technique was not widely or globally adopted. And here's why. Number one, it was developed as a technique that I could teach to doctors all over the world. I could decide at the time of surgery to do it. Patients would benefit from it, but there was no product or a company to sell to doctors or to patients. And so companies didn't go out around the world and teach doctors how to use it. They taught doctors how to use their equivalent, they thought, procedure, none of which really worked as well as paste grafting itself. The other thing is that paste grafting was a little bit difficult for surgeons to do. They'd pack the paste in, but they weren't really sure if it would stay or not. And then thirdly, we published that only about 30% of the patients were really normal articular cartilage. And doctors worried that, hey, if it's not normal articular cartilage, would it wear out sooner? Would it be a lasting procedure? And so with that, we challenged the foundation and came up with all the new things that have occurred since 1991 when I first designed this thing. PRP, stem cells, better ways of using both electricity, magnetic shock wave, other things to stimulate cartilage to heal. Could we add factors to the paste? And could we add all the new things that we had learned over the last years and create a better solution? And so ArtCart Plus is our process for going out and figuring out which additives to paste graft and what techniques will make it better. And Dr. Vessal is going to describe how we're going about doing that.
Great. So yeah, what are we doing to make this a better technique, more improved technique? Science improves over time. Regenerative medicine and the science of regenerative medicine is still at its infancy, is what I call. I've been in this field for about 25 years in various aspects of disease models and human diseases. And I have seen an exponential growth in the hope and in the growth of regenerative medicine as a whole, stem cell therapies and otherwise. So this is where it comes really handy for us. And we are, of course, utilizing every little bit of the newly developed techniques and more improved science in this young field. And we're using it to our advantage to build a better cartilage. Okay, so in this light, going to the next slide, what do I mean by that and why are we doing it? Again, the impact is very important. We want to make this a globally accessible procedure and to make a stronger cartilage, more durable, healthy cartilage. And also very important to note is that it will benefit all ages. You don't have to wait to the age of 60 or 70 as it is to replace your joint. We don't want you to do that. If we can slow down that process or even prevent it from happening, that is the ultimate goal by regenerating your own cartilage. And also, as I will just describe and get into it, this is not just going to be beneficial for the humans. It's also going to be very much so advantageous for our equine and canine patients. So on the next slide, I will go into a little bit more detail for you as to how this whole work started. We had a sizable grant from the California Institute for Regenerative Medicine, the stem cell agency here in California, that allowed us and enabled us to start this entire quest. First, we optimized the cartilage in terms of its preparation, and we optimized and characterized the cells in a dish to see how, when, and what kind of an environment will make the best cartilage from these stem cells. And we added other sources to augment it for better adhesion to the site where it is transplanted in the animals and therefore in the patient, and added other factors, as Dr. Stone alluded to, stem cells and or growth factors for even better regeneration of cartilage. So this work, as a next advance from the conclusion of our work from CERN project, we basically started a collaborative partnership with Dr. David Frisby and his team at Colorado State University, a leading equine center globally, to take the results that we have to the next, what we call translational, which is a preclinical stage of our project that will then lead us to the clinic for clinical trial. And this work is done in the horse model, since it is quite relevant to that of a human knee. From biomechanics and load bearing, it is looked at as a prime model. And so not only will this be a therapy that will be available to the equine patients and canine patients eventually, but also it will inform us very well to lead us to the human clinical trials for the ArtCAR Plus 2.0. Now, where are we today with that? I met with one of the head of the FDA officials in Copenhagen at a meeting in October of last year to discuss the protocol for this project, both in the equine and where we're going with it to the human clinical trials, to make sure that everything that we are doing is in sync with the regulatory body, with the FDA. And then we started this project in December of last year, part 1 of part 2 of the horse study. And we are now towards the end of part 1, where this will be concluded in December of this year. We have already looked at mid-year results with the scope, and we are seeing quite encouraging results with cartilage regeneration in some of the groups. And by next year, around mid-summer, is where we plan to commence our part 2 definitive study that will lead to an in-market veterinary use for this therapy in the equine and in the canine joints by early to mid 2028. And that will set us up for starting our human clinical trials by late 2028. Again, the impact. I will keep going back to this because it is our entire goal is to make this a globally accessible procedure and to give you a stronger and better durable cartilage. And it will benefit all ages of all sorts. And of course, it will be a veterinary application that will be an added plus. Here, I would like to introduce as a testimony one of the patients, and speaking of all ages, Natasha Ali, who is a 33-year-old female who suffered from multiple fractures in her ankle and underwent an ArtCAR procedure with Dr. Stone about 2 years ago. And I would like to show her testimony just so that you can hear it firsthand of her improvements.
My name's Natasha, and I had the articular cartilage paste graft. I had a lot of difficulties before I got here with my ankle. I was unable to do more than 20 minutes of walking until I would come home and then just have to lay down for the rest of the day after doing that amount of walking, and it would be really painful, especially in the winter. I opted to come to San Francisco because I did a lot of research on what I could do other than having an ankle fusion, because that was the next step for me in the UK. All the consultations that I had with different doctors in different parts of the UK, I even went to Dubai and had a consultation there as well, and they all pretty much said the same thing, that I would need to have an ankle fusion. And one night I was just continuously researching, and I came across the Stone Clinic, and I just knew in my heart that that's what I wanted to have done. I opted for that because I thought it would be the best option for me out of all the options that I was given. I just thought that that would be the best. I feel like I want to do things that I've never been able to do before. So the first thing is I really wanted to get into like Pilates and doing yoga, and like half of those movements I wouldn't have been able to do before. And I can already see that I'm going to start being able to do those as time goes on. I've already started doing squats, and that was one of the things that was something to me that I couldn't do before. And I'm already starting to do those now. So I know that I'm going to be able to do things that I've never ever been able to do in my entire life. Well, I say entire, it might as well be 18 years I haven't been able to do stuff like that for. So I just know it's going to be life-changing. I'm looking forward to the future and walking miles and miles and miles.
The third one was, once you've had to have surgery, how we can get you to basically recover faster and get on with your active lives pain-free faster. That's the testosterone therapy, which is the post-surgical project that we have. And I'm going to let Dr. Stone take a shot at this one and explain it in full as to what the goal is. Dr. Sun, you're mute.
Thank you, Mani and team.
Yeah.
Hear me better now? So if I ask a patient a year after knee surgery, what was the worst thing about it? Almost every patient says it took me a year to rebuild the muscle. You know, I had to go to physical therapy extensively. My muscle atrophy kept me out of doing this activity or another activity or back to, work or military action. Are you hearing me okay? Muscle atrophy is the sort of number one problem that most people have after extremity surgery. And so the question is, can it be prevented? Next slide. And so what happens when I hit you with an axe, otherwise known as surgery, or when you have a big trauma, you get an enormous stress response. And that stress response is primarily driven by a big cortisol release to the body. The effect of that and other factors induces muscle atrophy within 8 hours of the surgery. So the question we asked was, if we gave a patient an anabolic steroid, a testosterone, just before surgery and a second dose a few weeks later, could we prevent the initiation of that significant muscle atrophy? And we did a pilot study funded by one of our grateful patients, where we looked at the quad girth by MRI. So an MRI before surgery and MRI at sequential times later on, to assess the amount of muscle loss with and without the testosterone protection. And of course, a pilot study is just for safety per our IRB, our Institutional Review Board. And we're now teed up to do a wider, bigger study, since the pilot study showed that it was safe. But in order to do the wider study, we asked a second question, which is, what if you don't know that you're about to be hit by an axe? What if you just have a car accident or trauma or tear your ACL on the pitch? So in collaboration with a team at Duke, who did brilliant work on using testosterone for ICU patients, where they gave every patient going into an ICU, both men and women, and looked at how much it shortened their ICU stay or sped up their recovery afterward. So those patients clearly didn't know that they were going to end up in the ICU, and used testosterone as a therapy to accelerate their healing. And so in collaboration with Paul Wishmeyer at Duke, we're hoping to do a wider study than just my surgical pre and post-op, but include an arm that is people who had an injury and initiate the therapy immediately post-injury, and evaluate both groups of patients in a larger study. And so we're excited about that. We think that this field of both using testosterone tactically fits into what I call a wider field that's yet to be explored, called male hormone replacement therapy, or as you're aging, are there certain hormones that we could use the way women have used them with estrogen and progesterone? Should males be using some of those to defer some of the effects of aging? That's a bigger topic and a wider discussion. But before we can get to there, we want to see, can we use testosterone tactically to diminish the atrophy immediately after surgery, before and after surgery, and after trauma? So we're hoping to get this study funded. It's in preparation now in collaboration with the team at Duke, and we would love to see that one completed. We'd love to be able to help people accelerate their healing from surgery or from injury, clearly for the faster return to normal activity and minimizing downtime. So I think we're going to turn over to Mark Bailey now. Mark and Laura are fantastic people in their own right, but also they get the fact that medicine, whether it be in the cardiac space or the orthopedic space, has a dramatic impact on the quality of your life. And they have been wonderful patrons of the Stone Research Foundation, and lovely to be around people who see that if we're going to keep you playing forever, we better push hard on this research.
Amen. Thanks for those kind words. Hey, we're all here because I think we share the belief that movement is life and life is movement. My wife Laura and I have both been patients at the Stone Clinic, and we're both very grateful for the work that the clinic has done and the work that the foundation has done and continues to do. Some of you may be aware that the foundation is launching a capital campaign to fund some of this very exciting research and essentially a moonshot. And using the mentality, I'm speaking to you here from the heart of Silicon Valley, but it's defined as kind of the greater Bay Area. And the mentality is to do things, question convention, and do things that are creative and different and make a real impact. And that's the spirit that the foundation is undertaking as it contemplates these moonshots of having the ability to regrow knee cartilage and allow people to avoid perhaps surgery, perhaps a lifetime of arthritis and arthritic pain, and also ways to use testosterone to speed healing, and do that perhaps from the onset of the injury. And so we're pleased to be part of that effort, and you can expect to hear from a member of the Stone Research Foundation team in the coming weeks about this capital campaign. The great thing about capital campaigns is it energizes everybody. It gives us something to shoot for. And in this case, when we think about the next 5 years, that takes us into the next decade, 2030, which for many of us sounds like the future, and it really is. So why can't we have these kinds of techniques available more broadly to those of us who do in fact want to play forever? We hope you will join us in supporting the foundation in this important work that they continue to do.
Thank you, Mark. Mani, are you there?
Yep. Thank you, Mark. Thank you so much. As always, grateful for your support and the energy you infuse, and Laura, of course, infuse into the foundation with your enthusiasm. I would like to next go ahead to the Q&A, and I'm sure we've been getting a whole number of questions through chat, and I'm going to let Dave Hopkins, our Director of Communications, who's going to moderate these questions, and hopefully we can answer as many as time will allow us within the time frame that we have. Dave, are you online with us?
Yes. Yeah, thanks for the introduction, Mani. I'm the Director of Communications for both the Stone Clinic and the Stone Research Foundation. I've been fortunate enough to hear some of your stories that are here on the line or connect with you in terms of supporting the foundation. So great to see everybody here. Thanks for taking the time to learn about our work and discover, how we can push together and create some real change. We always include a Q&A because we want to hear what you have to say and what gets you excited, and what more about our work we can share. So I'm going to start sharing some of the questions that we received ahead of time, but please include them and I can also try and get to those if we have to. I'll start for one. I'll just kind of direct them to you, Dr. Vessal or Dr. Stone. First one that came in here, I think, was from what our interns are. How are patients and physicians informed about the work that you plan to do with orthobiologic injections?
Dave, you should answer that.
Well, that's how we speak to patients, and I can say how we do that. Dr. Stone writes a lovely blog each week that we really aim to help inform the choices that you make about yourself. It's not a really clear path to perfectly protect your joints, and so that's how we do it through the clinic. But I think this is more in terms of how are physicians finding out about the work that you guys are doing.
I'll take the first stab at it, and then I'll let Dr. Stone chime in after. So as with any other scientific findings, of course, we will publish our results in the most appropriate scientific journal or medical journal, where we will basically report back to the entire medical community what the newest findings are. In addition to that, Dr. Stone and I, and sometimes a team, we travel to numerous meetings and conferences internationally and nationally, where we present our data on our newest findings on any of the aspects of our research. So these are all, of course, in the public sort of communication side. Dave, with your help as well, and of course on our website, we will always present the newest of our findings as well. Dr. Stone, I will let you take it.
Well, I think you guys did a great job. That's part of our mission is teaching and education. So part of it is I run around the world teaching other surgeons how to do these techniques, and that then multiplies the effect for patients around the world. And we go around and lecture as well. I'm on my way to Boston to the International Cartilage Repair Society meeting this weekend, and we use the academic environments by publishing our papers, by giving talks, by having peer review of what we're doing to make sure that we're doing the best quality science possible and that we're keeping it objective. So we'd love to hear from you guys as well.
Yeah, okay. So have another one in here. Dr. Stone, maybe this is a good one for you, since you're a clinician and this is a very important thing that you consider. What side effects have been noticed with all the three treatment options discussed here today? So the biologic injections, ART-CART, and testosterone.
So biologic injections have been stunningly safe. And let me explain why. You would think that, injections of lubrication and PRP and anabolic factors and Wharton's jelly, and you would think with all the injections going on now that there would be infections or that there would be complications. And we have not seen a single complication from these injections that I'm aware of. And when other researchers present their data, we see that as well. And here's why. Let me use an example of Wharton's jelly for a minute, just because it's maybe the most dramatic. So the reason the mother doesn't reject the fetus, even though the fetus is only half the mom, is because there are potent factors within the amniotic fluid, within the blood in the womb that are immunomodulatory, meaning they shut down inflammation. They're antibiotic, meaning even though there may be excrement from the fetus, the mother doesn't get an infection. They're antifibrotic. They stop scarring. They recruit the body's own stem cells to the site of growth. So all of these things are potently positive. And when we use these tools in people's knees or ankles, especially even PRP, one of the mechanisms of action is recruiting the body's own stem cells to that site of injury, which are potently antifibrotic, anabolic, antibiotic, immunomodulatory. And so the complication rate from these injections is extremely low, especially if good sterile technique is used. And I think that's what's going to happen going forward. One of the goals of our research, as Mani went through so elegantly, is how do we sort through these various things to find the most potent of them to use for patients. And one of my jobs as a clinician is to figure out how to do the maximum number of things for you and the minimum number of things to you. And so to the degree that we can optimize these injections and make them more potent, then we'll diminish the amount of surgery that we need to do. And we seem to diminish the complications. Now, let me also add that when we do a surgical procedure, we're now very commonly adding these orthobiologic injections post-surgery to augment the healing, to decrease the scarring, to do all the things I just mentioned. So they're going to be an adjunct to almost all the surgical techniques that we now do.
Thank you very much. You already answered another question that we had in here from someone, so thank you for that. It seems like there's a great number of questions about the articular cartilage paste graft or ART-CART. This question came in here. How is ART-CART Plus compared to the traditional first iteration of the paste graft in animal studies? And do you expect to see improvements in humans as well?
Yes, and so one of the complaints about the original ART-CART is that it didn't go in like grout in a hole in the wall. It sort of went in as a paste, and it wasn't clear that it was sticky enough, and it was difficult for the surgeons to use it. So one aspect is the handling characteristics of the paste will be improved by the addition of a sticky hydrogel that's added to the paste. The other aspect of it is patients always want their tissues to heal more rapidly so they can return to running. And we were keeping people off running for almost a year after we would do a cartilage repair procedure. So by adding the stem cells, by adding other growth factors, the hope is that we will accelerate the healing. And so in the study that Dr. Saul mentioned in horses in Colorado State, we will be looking at those biopsies in the next month to determine the rate of healing, the amount of maturation, that occurs in the different formulations that we added to determine which one is most likely the best one, and then go forward with a definitive horse study after that before we go into people. So yes, we think adding these anabolic factors is the way to move forward. Somebody also asked the difference between paste and plugs and other procedures on the market. I mentioned that in that slide where I showed the advantages to paste. Plugs are where a surgeon takes an intact round plug of cartilage and bone and takes out a round socket out of the damaged knee and inserts the new plug, like a hair transplant almost, in a larger sense. The problem for us is that many arthritic lesions are not round. And also the shape of the femoral condyle or in the ankle joint, they're not flat. They're really complex shapes. And it's almost impossible to match these complex shapes with a plug that also has the same complex shapes. And so we think the body does a better job molding it with motion in order to provide healing. That's why we prefer a paste to the other procedures that are on the market.
I will add one more point to the on the question. We are every group in every one of these studies has a built-in positive and negative control groups. In other words, we do have the traditional paste also side by side in every one of these studies to do a direct comparison as to see the extent to which the significance of improvements in any of these groups that we're testing is compared to the. So that's the traditional paste in the animal in your question versus the new. And hopefully we will see that reflected in the humans, of course, once we get to the human clinical trials. On that note, I see the time is 1:55, and unfortunately we have to wrap this up. And so if you have any further questions, and I know that there's a large number of questions in the chat, please feel free and don't hesitate to email it to researchteam@stoneresearch.org. And any of us here in the team would be more than happy to answer your questions. And I, along with the team, thank you for attending this session. And hopefully we will see you soon again with more progress on the foundation.
And before we end, I'd like to just thank the team, the research team, Dr. Vessal and Cimarron and Florine and the whole team, that Dave especially, who helps us communicate the passion that we have for solving these problems to you. Without them, there's no way we could do that. And just know that we're all driven in the space. We think the science is fantastic. The opportunities to help people are endless, and we're jazzed to do it. So thank you for sharing with us.